Good evening, my name is Ben McCormick, and I'm a third-year resident at Mayo Clinic in Florida, and I'll be talking to you about an 85-year-old female with lichenoid eruption due to pembrolizumab. So pembrolizumab is an immune checkpoint inhibitor commonly used for many types of cancer and has been associated with a wide range of immune-related adverse events. One of the uncommon cutaneous forms is lichenoid eruption, and there are limited evidence-based guidelines to manage this complication. So we present an 85-year-old female who presented to the ED due to diffuse progressive rash with pruritus. She had active metastatic bladder cancer and had received 4 cycles of pembrolizumab. 2 weeks prior to her initial presentation, she developed skin lesions that had evolved from scattered pruritic macules to diffuse plaques covering all of her extremities. So on arrival to the emergency room, her vital signs were within normal limits. On physical exam, she was cachectic with a BMI between 15 and 16. She had mild oropharyngeal mucositis with angular cheilitis, had a right subclavian port without evidence of infection, and had no cervical or axillary lymphadenopathy. On dermatologic exam, she had skin lesions on all of her extremities and face, and they were noted on her lower extremities to have impetigo with negative Nikolsky sign. However, there was purulence present in multiple lesions of the upper and lower extremities. And in the middle of the screen, you can see the lesions on the right dorsal hand and right upper extremity, which revealed diffuse violaceous plaques and erosions with adherent hemorrhagic crusting. As far as laboratory findings, her white count was normal. She had a mildly elevated CRP at 39 and an ESR of 96. Dermatology was consulted and ended up doing a skin biopsy with culture, and those cultures ultimately resulted with Proteus mirabilis and MRSA. Regarding other biopsy results, you can see that in the bottom figure, a low magnification H&E of one of the biopsied lesions showed lichenoid dermatitis with focal subepidermal clefting on the left, and then the higher magnification form shows lichenoid dermatitis with eosinophils as seen on the right. So ultimately she was treated with IV antibiotics for purulent cellulitis, initially with vancomycin and cefepime, which were then narrowed to trimethoprim sulfamethoxazole after culture sensitivities resulted, and she completed a 7-day course of antibiotics. For her immune checkpoint inhibitor lichenoid eruption, she was treated with 1 milligram per kilogram of prednisone for 4 weeks, and pembrolizumab was permanently discontinued due to the severity of presentation being a grade 3 checkpoint inhibitor cutaneous eruption. So 1 month after hospital discharge, the patient experienced complete resolution for cutaneous lesions. However, due to progressive metastatic disease and these severe reactions to immunotherapy, she ultimately decided to elect for palliative care only without further oncologic treatment. So a brief overview of immune-related adverse events, specifically lichenoid eruptions. They are seen in up to 6% of patients treated with anti-PD-L1 or PD-1 therapies, but are fairly uncommon compared to the other cutaneous manifestations and typically occur later in the course. So most commonly they occur 6 to 12 weeks after initiation of immunotherapy, whereas the maculopapular and psoriasiform rashes occur earlier. And steroids are the mainstay of treatment for all immune-related adverse events. For the lichenoid eruption specifically, they aren't addressed in current NCCN guidelines, but extrapolating from other guidelines for maculopapular rashes or bullous dermatitis, grade 1 can be treated with topical treatments. However, grade 2 to 4 should be treated with systemic steroids, and anyone presenting with grade 3 or 4 disease should be treated, not continue any immunotherapy going forward. However, there are limited evidence-based guidelines as mentioned, and so further trials should be considered with prospective data in the future. And that is a summary of our case, and thank you for listening.